Now let us talk about hypertension during pregnancy. We have a gestational hypertension, mild and severe preeclampsia, HELLP, which include hemolysis, elevated liver enzymes and low platelet, and eclampsia. They are all the various classes that fall under hypertensive disorders of pregnancy. But mainly we discuss in the form of four main headings which you need to be very sure about. Pre-existing or a chronic hypertensive who became pregnant, and how are we going to manage? Pre-existing hypertension. When do you consider this as a diagnosis? Suppose if the hypertension is there prior to the pregnancy itself, or if you first time happen to see that pregnant women and before 20th week only if hypertension is there, it is more likely to be called as a pre-existing or a chronic hypertension. How much hypertension? Systolic BP more than 140, diastolic BP more than 90 on more than one occasion. Prior to the 20th week of gestation, that word 20 is important to call it as pre-existent hypertension. Then if you look at the one more important thing is, if the hypertension persists beyond 12 weeks after pregnancy also, it would have not, it can't be called as a pregnancy induced hypertension. Rather, it should be considered as a undetected pre-existent hypertension. Usually, you don't see any proteinuria or end organ damage if it is a well controlled pre-existent hypertension. You don't see any proteinuria or end organ damage. Then gestational hypertension. It is also called the transient hypertension or a pregnancy induced hypertension is the name which is used for gestational hypertension. Once more, criteria are the same. Systolic more than 140, diastolic more than 90, but after the 20th week of gestation, then you call pregnancy is the culprit. Pregnancy induced hypertension, that word 20 once more, after the 20 is very important to be remembered. Even in these people also there will be no proteinuria, no end organ damage. When do you call preeclampsia? Hypertension with proteinuria after the 20th week of gestation becomes preeclampsia. Once more in that, what is meant by mild? If the BP is more than 140 systolic, diastolic more than 90, twice 6 hours apart at bed rest if you evaluate. If the proteinuria is only 1 plus on the dipstick or more than 300 milligram per 24 hours without any other subjective symptoms. So at 24th week pregnant women found to have hypertension and you have done complete urine examination found to have 1 plus proteinuria, then you call it as still a mild preeclampsia. When you call severe, doctor, suppose if the systolic BP is more than 160, these values are important, or a diastolic BP more than 110 twice 6 hours apart at bed rest, with or without end organ damage, along with any of the other problems like neurological. If the patient is having eclampsia or a frontal headache or scotomas, eclampsia means presence of seizures due to preeclampsia, then that qualifies to be called as severe preeclampsia. Renal, if there is a proteinuria more than 5 grams per 24 hours, or if the oliguria is there with less than 200 cc per 24 hours, if these are the associated findings, that qualifies to be called as severe preeclampsia. If the GIT symptoms are there like epigastric right upper quadrant pain, because the hepatocellular ischemia and edema, which is causing the Glissen's capsule of the liver to become stretched, leading to a epigastric or a right upper quadrant pain. And if you do LFT, if there are elevated SGOT, SGPT, that is also an important way to call severe. Patient can have pulmonary edema. Hematologically, there can be thrombocytopenia or a microangiopathic hemolysis with an elevated LDH. If you examine fetus may develop IUG or oligohydramnios when these are all attached with that high BP. Then you call it as severe preeclampsia is what need to be remembered. Then the next important class of hypertension is superimposed preeclampsia. Suppose already there is a chronic hypertension, before 20th week only you found hypertension. And if it is a pre-existent hypertension, you don't expect proteinuria. But if proteinuria also develops in them, then what do you call preeclampsia superimposed on the pre-existent hypertension? That's how you basically divide. Now comes a very important question. Patient will tell you, doctor, I already have BP. What is the chance of my getting preeclampsia? All women who already had hypertension, suppose 35th or 36-year-old pregnant patient is there, doctor. Nowadays, getting at 30 itself, hypertension has become a style in India. So she will tell, I already have hypertension, doctor. Is there any chance of my getting proteinuria and preeclampsia? 1/4 of the pre-existent hypertensives will end up in preeclampsia superimposed on the pre-existent chronic hypertension. So any increasing proteinuria after the 20th week of gestation becomes the preeclampsia, and when the hypertension started doesn't matter. If it is a hypertension started before 20th week, then you consider it as a preeclampsia superimposed on chronic hypertension. If the hypertension occur after 20th week, in a case with proteinuria is essential to call it as preeclampsia. Only hypertension is not sufficient to be called as preeclampsia. So basically hypertension occurs a little earlier in pregnancy if it is superimposed one. And superimposed pregnancy will lead to a more severe form of the fetal growth retardation. Why, doctor? Suppose if it is a pre-existent hypertension, some amount of vascular angiopathy will be there. That will affect the fetal blood flow. And hence IUGR is more severe if it is a superimposed preeclampsia rather than a preeclampsia developing only at the time of that pregnancy. And also abruptio placentae, one of the risk factors we said preeclampsia, no? This superimposed preeclampsia will increase further the risk of abruptio placentae. So what is the pathophysiology of preeclampsia, doctor? Vasospasm. Why brain is involved, why kidneys are involved, why liver is involved, why SGOT, SGPT elevate, why there is a subcapsular edema in the liver? Because vasospasm to the kidneys, to the lungs, to the uterus and to the brain is the underlying cause. For which, what is the cause? We don't know. I mean, it is still idiopathic. So what are the risk factors for the development of preeclampsia? But before we go to the risk factors, let us look at the renal biopsy of the glomerulus in a case of preeclampsia. Reactive endothelial cells which are causing the narrowing of the capillary lumen is a classical histological finding. So if you look at the pathophysiology, some genetic factors are a faulty placentation, excessive trophoblastic activity or any maternal vascular disease, any of them will lead to reduced uteroplacental perfusion. The reduced perfusion will lead to endothelial activation. You know, endothelium is a powerful chemical bomb. It will release the mediators which in turn will lead to the development of the vasospasm. which lead to all the problems like liver ischemia, abruptio, oliguria, seizures, hypertension, blah blah blah, is what you need to understand. So doctor, what are the risk factors of preeclampsia? Some pregnancy associated factors, chromosomal abnormalities, presence of hydatidiform mole can lead to preeclampsia. Hydrops fetalis is another important risk factor, very important to be remembered. Multifetal pregnancy, twin pregnancy, triplets, quadruplets, they all lead to preeclampsia. And UTI, similarly, any oocyte donation or donor insemination has led to that pregnancy. Such pregnancies will have higher incidence of preeclampsia. Then certain maternal specific factors. If the mother's age is more than 35 on one end, or even if it is less than 20, teenage pregnancies also can lead to the development of preeclampsia. Family history. My mom, my aunt, my great grandma, everyone had a high BP during pregnancy. Nulliparity is a risk factor. Previous pregnancy, preeclampsia will remember and lead to similar preeclampsia this pregnancy. Then there are certain specific medical conditions which can lead to preeclampsia, like gestational diabetes or type 1 diabetes or any chronic hypertension in the mother. We said no, 1/4 of chronic hypertensives will end up in preeclampsia. Maternal renal disease, maternal thrombophilic states like antiphospholipid antibody syndrome can be a predisposing factor. Stress, then there are certain father specific factors also. First time father, there is nothing like first time mother. First time father will also is a predisposing factor for the mother to develop preeclampsia. Then suppose if a guy married, his first wife had preeclampsia, they divorced, and now he made another woman become pregnant, second marriage. Can the previous woman who developed preeclampsia due to this guy who led to this pregnancy, can it be a risk factor? Yes, sir. So previously fathered a preeclamptic pregnancy in another woman can be responsible. That's the reason. Always check the credentials of the guy, how well he was good in the bed, and after that what was the risk factors which happened during obstetrical situation. Second wife can take a feedback from the first wife. Then angiotensin gene P235, those who are homozygous, they are also known to be the risk factors for the development of preeclampsia. Now what are the complications? Abruptio, it can lead to eclampsia, intracranial hemorrhage, blindness can develop, and renal failure, coagulopathy, hepatic subcapsular hematoma, uteroplacental insufficiency, they are all the problems a preeclamptic pregnancy typically will have. So microangiopathic hemolysis leading to the development of cystocytes, red cell fragments, is one of the hallmark which you may see if there is a microangiopathic hemolysis. So how do you want to treat, doctor? All problems are brought by the pregnancy. Ask the fetus to live. Delivery of the fetus is the only way to treat the preeclampsia. In fact, if you look at eclampsia, suppose in a eclamptic woman, in a preeclamptic woman, you have emergency put on cesarean. After the cesarean is completed, the baby is delivered. While putting sutures, she may develop seizures and end up on operating table with eclamptic seizures. Is also possible. Okay, doctor. So preeclampsia comes down only if you balloon out the baby, is the question. Now comes in what situation you need to speed up the delivery of the baby? What are the indications in the fetus for delivery, emergency delivery of the baby. Suppose if the baby is having severe intrauterine growth retardation, severe IUGR, or if the fetal tochogram is showing a non-assuring pattern, or if there is a oligohydramnios. Common reason for oligohydramnios is what, doctor? Rupture of the membranes, leading to the leakage of the fluid, leading to low fluid, and preeclampsia is there on the top. That becomes an indication baby has no more cushion to stay inside. Ask the baby to come out. Then what is the maternal indication? If the mother's gestational, the gestational age of the pregnancy is more than 38 weeks, oh, no more waiting and watching policy. Ask the baby to come out. If the platelet count is below 1 lakh, that means she is going into HELLP syndrome, becomes an indication for the fetal delivery. Progressive deterioration of hepatic function or a progressive deterioration of the renal function. And if there is any placental abruption suspected, or persistent severe headache or visual changes, or if there is any persistent severe epigastric pain, nausea, vomiting, or if there is a eclampsia developing. In eclampsia there is no role for watching, waiting, observation and pleading the baby. Make the baby get out, irrespective of gestational age. If seizures are there along with preeclampsia, once eclampsia develops, no role for observation. Get rid of the baby is what you need to do. So always in a woman who has high risk of the preeclampsia, she must receive a baseline sonogram. In the sonogram you can identify how is the placental blood flow, how is the resistance index, how is the flow pattern, by which you can identify the placental umbilical artery flow resistance, which is one of the very early indicators that the preeclampsia is going to develop. Because we said, no, what is the underlying pathology? Vasospasm. So the vasospasm is there, the placental blood flow will show increased resistance. Then that is an important indication that preeclampsia is going to develop. So you also need to evaluate the fetal growth by doing a baseline sonogram. So what is the management algorithm in case of preeclampsia? So doctor, you assess the mother and the fetus. If the gestational age is more than 37, or suppose if it is more than 34 but there is a severe preeclampsia, or if there is a rupture of membranes with the loss of the amniotic fluid, or if there is any labor or abnormal fetal testing or severe oligohydramnios or a fetal growth restriction, if it is there, then no more waiting, deliver. If these things are not existent, if it is a mild disease, mild preeclampsia, but the gestational age is only less than 37 weeks, that means fetus lung maturity has not yet achieved, but it is only a mild preeclampsia, then what will you do? Basically you do maternal fetal assessment. Only if there is any worsening of the materno-fetal condition, or if there is a labor or rupture of membranes, or if the baby crossed more than 37 weeks, then only delivery is indicated. Suppose if it is a severe disease and the gestational age is less than 34 weeks, then give a shot of steroid. Give some time for the baby's lung to mature, right? Then give antihypertensives, daily do an assessment of the materno-fetal condition, and once the baby crosses 34th week, then you can deliver. So that is a typical plan. Now, so that's the reason, doctor, severe preeclampsia versus mild preeclampsia, you must be very sure on the management protocol. Now, if there is a pre-existing hypertension, or if there is a transient hypertension, or if the patient has a chronic hypertension in pregnancy, what do you want to do? Always there is a debate between close observation versus giving antihypertensive. See, ACE inhibitors are absolutely contraindicated as antihypertensive. Beta blockers will predispose to IUGR. So everything has its own problem. Calcium channel blockers will lead to the smooth muscle relaxation and will prevent labor from getting started. So like that, everything has a problem to use antihypertensives. So observation always do have a role in the management, because a good number of times antihypertensives are known to adversely affect the fetal well-being is what need to be remembered. Then max sulfate. In any of this group, pre-existing hypertension or transient hypertension or chronic hypertensives, they have a risk of ending up into severe preeclampsia with eclampsia, possibility of eclampsia. Is there any way to prevent the eclampsia from developing? Prophylactically, can you give something to prevent the development of eclampsia? Yes, sir. Max sulfate has got a very important role as a seizure prophylactic agent. Remember, max sulfate has no role in hypertension management, only for seizures. Treatment of already started seizures or prevention of the development of the seizures prophylactically in a case of pre-existing hypertensive, it has got a role. So, if it is a mild preeclampsia, what do you want to do, doctor? Look at we are repeating the same thing which we already have finished. Look whether it is preterm. If it is preterm, closely monitor for the worsening and do the fetal testing religiously by doing non-stress tests and BPP to know the fetal well-being, and decreased physical activity is recommended, not bed rest all the way. Suppose if it is a term fetus with a mild preeclampsia, what will you do? Delivery. Now, just because it is preeclampsia, is it an indication for cesarean? No, sir. Vaginal delivery is usually attempted, trial labor. Cesarean is only if there is any definitive obstetrical reason, then only it is indicated. And you need to give them max sulfate for seizure prophylaxis. If it is a severe preeclampsia, what do you want to do? If it is a very preterm, I am trying to revise the same thing which we discussed in algorithm. Very preterm, less than 28 weeks. Hospitalize the patient and closely monitor the patient in the hospital. And if it is preterm or term, don't wait, deliver. And in this case, why are you doing delivery? Severe preeclampsia. So, at least mother should be saved. That's the idea. Huh? But it is not favorable for the baby basically, if it is preterm. And vaginal delivery is usually attempted. Even in severe preeclampsia, when you are doing the delivery, vaginal delivery only is indicated. And cesarean is only for the obstetrical reasons, and you need to start max sulfate. Now, doctor, HELLP, what does it indicate? Hemolysis elevated liver enzyme with the low platelets. And if this develops in a case of eclampsia, high morbidity, if it develops, no waiting watching policy, immediate delivery is indicated, and it's not needed that always there should be hypertension for HELLP to develop. There can be HELLP even without hypertension also patient can develop. That's the point that you need to carry home. Now eclampsia. Eclampsia is associated with seizure or coma, and there should not be any other reason which can explain them in a patient who is having preeclampsia. So eclampsia can ultimately lead to seizures if they are not well controlled. Hemorrhagic stroke can occur, and that can lead to death. So this is an autopsy of a 40-year-old woman who has severe preeclampsia and subarachnoid hemorrhage. Subarachnoid bleed has happened and she ultimately died. So this reason you have to meticulously manage the eclampsia. In fact, prevent the development of eclampsia is much better. So, when will eclampsia develop? Only 1/4 of them will develop before labor. Half of them will develop during labor. And 1/4 of them, even during postpartum period until 10th day postpartum, there is a risk for developing eclampsia, is what you need to ultimately remember, doctor. So if the eclampsia is there, the women with seizures presenting to you, what do you want to do? A, B, C, airway, breathing, circulation. Always rule out other possibilities like head trauma or cerebral venous thrombosis also can present with seizures. And pregnancy being a prothrombotic state. If prothrombotic state has led to development of central sinus venous thrombosis and that is causing seizures, don't run and jump. You need to anticoagulate and treat it. So that's important, right? Cerebral tumors first time may present during pregnancy and can lead to seizures. Drug overdoses can occur. Epilepsy, previously only epileptic disorder is there in a woman and her epilepsy worsened during pregnancy. Don't misdiagnose it as eclampsia. So these are all the things that you need to be very sure about. So whatever it is, seizures have to be controlled using max sulfate is the only anticonvulsants which is being used. Now doctor, at what concentration of the max sulfate you expect toxicity? Around 7 to 10 milliequivalents per liter. And what are the cardinal features of it? Max sulfate toxicity. Patellar reflexes, areflexia will be developing. So you need to carry a knee hammer to the labor room. Don't think that you have to carry it only to the medicine ward out of the fear of the medicine professor. No, even to the obstetrics. Respiratory depression, you must be ready to count the respiratory rate on a woman who received max sulfate. And there can be cardiac arrest. Oliguria can develop. So you should carefully follow the urinary output. So if the max sulfate toxicity develops, what is the treatment of choice? Calcium gluconate, 10% solution, 1 gram IV is considered to be the management of choice. So what is the rule, doctor? Max sulfate, magnesium, prevents the seizures but doesn't affect the hypertension is what need to be remembered. So you need to closely follow in a woman receiving the max sulfate, whether any areflexia is developing is very, very important to be followed. And delivery of the baby is the only definitive treatment. If there is eclampsia, what is the rule you are not going to forget, doctor? No role for the expectant management. Regardless of gestational age, you need to deliver and make the fetus leave. But if you decide to deliver, vaginal delivery is recommended. And in fact, with the onset of seizures, labor becomes speeded up. Spontaneous labor will speed up. Even when she is laboring, the duration of the labor also will shorten and a quick delivery of the baby will occur with the seizures. And to control the BP, what will you use, doctor? Hydralazine, labetalol are the ones which are used in eclampsia. So let us have a short review on various antihypertensives which we use in pregnancy. Hydralazine, what is it? Direct vasodilator. It can lead to SLE-like symptom and like any other vasodilator, it can lead to headache, palpitations. Labetalol, you can give intravenously or orally. Non-selective beta-1 and alpha-1 blocker, and it also carries a side effect of headache and tremor. Long-term control if you want to do hypertension in pregnancy. Methyl dopa, safe drug in pregnancy. It is a false neurotransmitter, centrally acting, just like clonidine. It releases the, can you open the door? Yeah. It typically it acts like a false neurotransmitter and it will cause the stimulation of the alpha 1 or alpha 2. Alpha 1, postsynaptic or presynaptic? Right? So presynaptic or postsynaptic, on what it will have agonistic activity, centrally acting ones? Post or pre? So once more, all that which we have reviewed in the obstetrics is highly essential. I mean, in pharmacology, you need to keep on revising, then only you will remember. So nifedipine, calcium channel blocker, but it can lead to edema and giddiness. Then can you use diuretics in pregnancy is a very important $1 million question, doctor. Diuretics are not used in pregnancy as antihypertensive. Very important point to be understood. They decrease the plasma volume, and that can lead to, that will have a detrimental effect on the fetal growth. Do you want to advise salt reduction in the management of hypertension pregnancy? No. It will also decrease plasma volume, not recommended. Can you give ACE inhibitors? No, sir. Absolute contraindication for the ACE inhibitors during the pregnancy because of their teratogenic effect.